I'm going to kill them. We need a celebration. Tempo yangu imetumika kwa sababu nilitafuta ingine.
Digital Skills for Africa offers over 40 free online courses. Learn new skills.
Oh wow. Yes, good morning everybody. Good morning again. Hamjakunywa chai? The line was too long. Yeah, I think it is preparation for August 9. The lines will be long again then. I'd like to take this opportunity to welcome all of you to this session. Asanteni kwa kuja. If you're seated at the back, please move forward so that we can have a more close interaction as we move along. So, just to start with introduction, my name is Dr. Ken Soy. I work for a private entity called Imperial Medical Group. We do outpatient medical care here in Nairobi. And we are learning how to do more advanced things, and we are happy to be part of this session. So we thank the organizers for the invite, and I'm taking on the challenge that we need to be more involved in the wider discussion in our public health space. Yes. Today we have 3 speakers here with us. I think I'll let them introduce themselves as they go into their discussions. So because of time, and also I think they are better placed to introduce themselves. So it would be imposing if I pretended to know who they really are. Yes, so allow us to do that. just a quick housekeeping announcement. So when you are speaking, you have a question to ask, please face the camera at the front. That's the main camera for our online broadcast. Yes, we'll have a plenary session later on where we can ask the questions after our speakers have spoken, and we'll invite questions there. So allow our speakers, because of time, to go through their presentations really quickly, and then leave time for discussions later on. Any other announcement? So I think we can begin. Our first speaker is Dr. Damu-Ke.
Good morning. I'll remove this temporarily just for purposes of this particular presentation. My name is Dr. Damu-Ke from the Ministry of Health and Kenya Biovax Institute. I am a specialist pharmacist by training, and I'm pretty sure you're wondering why she's going to talk about securing biodata. It's an area of interest for me, and I'm going to have this discussion today on a policy standpoint so that we can fully appreciate the breadth of this particular subject matter and possibly challenge ourselves to see where exactly we fit in the role of securing biodata. It even goes beyond blood products, even organ transplant. So this is just an overview. We have about 118.5 million units that are collected globally each year. And these are statistics from the WHO. And out of all of that blood that's normally collected, there's always a gap that's experienced in each country for its blood needs. But to ensure that that blood, wherever it is used safely, we have to ensure that the right blood or blood product and even organs in this particular discussion gets to the right patient at the right time in the right place. So generally, we're talking about data. What data is this that's normally collected when you give your pint of blood and you get your soda and biscuits or bread, depending on where you are coming from? You have the donor and recipient details, you have the screening data for any contamination, you have your blood grouping and cross-matching data. You also have the blood products that can be extracted from the whole blood, and you also have, in some research institutes, sequencing that happens to see basically a genomic makeup. So subsequently, we have to ask ourselves as Kenyans, as people who are in the healthcare space, as stakeholders in the healthcare space, why do we need to secure this data? To you, it is something as arbitrary as nimepeana damu. But beyond that, there is a lot of information that that blood contains that we need to be able to secure. So it's important for us to be cognizant of the fact that preservation and security of that biodata is important to maintain national efforts towards quality and safe blood services. For the recipients, it ensures that this biodata security prevents any avoidable deaths, and it also reduces mismatch incidences. For the donor, it gives them some motivation towards a culture of donation beyond blood to even organs. And further, there's a bit of information that comes back to the donor, especially after screening, and it's found out that they have some form of bacterial contamination or viral contamination. For the national areas, this security of data is actually a national security agenda because your blood contains a lot of information about who you are as a person. If somebody wanted to cause a catastrophic biological event, they would just need access to either a blood bank or just a pint of blood and just do some manipulation to it and release that into the ecosystem, and eventually there would be some very deleterious effects. And of course, there is the disease surveillance and research that this particular collection of blood or even organs can be used to inform any further policy decision points. So where exactly in the ecosystem do we normally have this fault points or strengthening points that we need to be aware of? we have to think about it this way. There's a subjective aspect of it. There's a personnel, reliability. Some of us here are healthcare workers who work in these blood banks, and your information collection and also your analytics and surveys and how you share this information is a point where we can be able to either strengthen or can be a point of weakness for this particular biodata. Objectively, there's the information which has the cyber component to it, which is the computer and data systems that we use. We're all Kenyans. We know that what is used in Makueni is not what is used in KNH, is not what is used in MTRH. Unfortunately, these data systems have been put in place, and yet we do not know who has control of the back end of this particular data systems. So we do not even know where our data is going to. And beyond that, we are not fully aware of the level of analytics that we need to do to ensure that that particular information set gets to the right person so that a proper decision is made. And of course, matters information sharing through these particular systems. Then, beyond that, the physical infrastructure, which is just basic physical security, and even how the staff works in such an environment. These are the main areas that we have to think about objectively and subjectively when you're thinking about securing biodata. So, where are we as a country? Generally, for blood and tissue, I'm pretty sure the experts in the room are very aware of what is happening. We have a lot of avoidable deaths that come about because of lack of access to blood and organs, specifically blood in this case, where we have about 35% of our maternal deaths caused by bleeding complications. There's lack of equitable access to life-saving emergency, safe, human-derived medical products by all Kenyans when they need it, where they need it. Remember the first slide where we say the right patient, the right product, the right patient, right time, right place. That needs to be the mantra. So legally, before the launch that happened about 2 days ago, we had a very gray area in terms of regulation. And even further than that, beyond blood, we are now talking about organs and blood products. So the regulatory space around that has been a bit unclear. There have been some laws, there have been some concept papers, some white papers about it, but it hasn't really been purely enforced and clear to even the practitioners themselves on what exactly they need to do to ensure that there is security of data. So this has more or less led to some unfair practices to the donors, the recipients, and even some of the healthcare providers. The data situation, unfortunately, because of the diverse systems that we have in place in our different setups, we are unable to establish an early warning system sign. But this is something that will be remedied over time because, unfortunately, if they're not speaking to each other, then you can't know where the situation is most dire and make sure that the relevant impact or relevant solution is taken in a timely manner. And also, speaking to the same data situation, we still have some lack of a command structure. What is implemented, let's say, at national government will not be what is implemented in one county, which is different from another county. So progressively, what has happened over time is that there has been a disjointed move towards strengthening systems that don't speak to each other. Which, of course, again, lead to stockouts of some strategic commodities, everything from our lab reagents to even airtime for our healthcare workers who need to contact the donors and the recipients on these matters. And, of course, reliable data tracking mechanisms on what blood and tissue products are available and where. I'd speak to this from a pure supply chain issue, where you would have a glut of blood available in Nairobi, and yet the need is in Mandera. So the logistics of that, beyond somebody sending out a tweet on social media asking for help, would mean that if you're not able to actually make sure that every single morning you're aware of what is available where, and also that ties into even the hospital systems, not just public, even private and faith-based hospitals, to speak to where they have a need, so that this is transmitted and also the supplies are sent to the right places at the right time, then we will not be able to win the war, as it were, in ensuring accessibility. So while that has painted a very dire picture of our situation, there has been some progress made as a country. You have participated in this conference, and day one, there was the launch of the policy on blood and organ transplant. In addition to that, an intergovernmental framework. I know that some of the practitioners here have a lot of experience pre-revolution and have also experienced the healthcare sector post-revolution, and can be able to state the challenges that have been experienced as a result of the decentralization of healthcare, and also the benefits that this has caused. But we also have to be aware that there has to be, we have to all speak in one voice, especially when it comes to data. If we are not able to do that, then we will allow ourselves to more or less sell our data to the highest bidder, for lack of a better descriptor, and not knowing where this data is going to and what it is being used for. Then, of course, the standards, which again have been neither here nor there situation. There have been some documents, there have been some education efforts towards ensuring that some standards are set. However, this hasn't been enforced to a point, and that's why there is need for us to actually familiarize ourselves with the policies and guidelines and even standards that have been sent out, either from the Ministry of Health or from various bodies that are working with the Ministry of Health. Then, under laws and regulations, we have to appreciate that as a country, for the first time in 2019, we were able to come up with an act to protect our data. Unfortunately, that particular act glosses over the health issue. It's there, but it's not as explicit. And it does have an impact on research and research findings. But even beyond that, now within the Ministry of Health, there's a specific bill that speaks to health. The e-health bill that's under development and has gone through a lot of stakeholder engagement. And we are hoping that it will pass so that it can speak to the Data Protection Act, and further to that, speak specifically to matters health, and whatever amendments that need to come from there will come from the stakeholders in the health space, to ensure that we are able to protect our data and ensure that we use it for the right thing. Then, of course, we have the Kenya e-health strategy, which expired, I think, in 2017, but it's currently ongoing a review that would speak now to all these other laws and regulations that have been put in place. In terms of infrastructure, there's been concerted investments in a telemedicine project that will connect all healthcare facilities to a central backbone that will ensure that the data feeds into that so that it informs national policy and planning. And in addition to that, under the UHC agenda, there's been work that the Ministry of ICT has been doing, the Ministry of Health, to connect health facilities, about over 140 in my last count, to ensure that this connectivity is done. But this doesn't speak to specifically donation centers, but this is a discussion that is ongoing so that they can be tagged onto this and ensure that there is a level of connectivity through that. Then, of course, our regulators. So, of course, Ministry of Health agencies. We have the KNBTS revamped, as it were, that will at least have some teeth to ensure that the standards that have been set out are actually enforced. Then we have the Office of the Data Commissioner. We should not take that particular office lightly. They're one of the first countries that sent out a guidance on how our COVID-19 data was going to be handled globally, and that came from the Office of the Data Commissioner. So these are things that we need to familiarize ourselves as stakeholders to ensure that we are alive to how we use our data and how it's supposed to be done. And finally, what do we need to do? We need to contextualize, develop, and pass out data protection laws and regulations. Other countries, other regions, other continents have been able to do it quite well, and they have their house in order. For you to access data from a data set from the EU, you have to go through their own data commission. For you to access data from the US, you have to go through several layers of approval. In Kenya, you just call your friend who has a passport, and they give you access to the database. So think about that. Of course, continuous stakeholder education and engagement for us to fully understand why this is happening, and also for us as stakeholders to lead into this particular matter so that we can be able to accept that we need to own our data. Beyond that, the healthcare work, training and education, again, ties into all of this. All of us need to be aware of why we're doing this. And of course, increase the investment in our data security infrastructure. Case in point, this is not health related. What happened in the US in the oil plant that was hacked into, and the US went into an energy crisis for about a week. There was a whole line that transmits fuel that was hacked into by some people from some European countries, and they basically stopped their fuel supply. That was an issue. So we need to increase our own investments into this, and we have the brains in this country to be able to do this, and we just need the willpower to be able to increase those investments, and of course, enforce what we have. Thank you.
Thank you very much, Dr. for that awesome presentation. I know it seems like we're running through things, and it's because of the time limits of the given. So our next speaker is Dr. Oroko, who will speak to us about world banking and the application in our clinical settings. Karibu sana, Dr.
Thank you very much. I don't know my audience very well. How many here are medical doctors or work in the medical field? Okay, so that helps me understand the language I use. I'm going to talk about the clinical needs and requirements of our blood bank. We are used to having a blood bank, but we also require blood. In practice of the things, we have instances. I have the So sometimes there is massive bone loss. This occurs after accidents where part of the bone in the leg or another part of the bone is left on the side, or infection where a lot of bone is destroyed, or if there is tumors, cancer, and we remove a large part of the bone, or in many operations in the spine, where you require a lot of bone to actually stiffen or fuse the bone. Or sometimes after a joint replacement, if it fails, there's massive bone loss. And right now, we struggle as orthopedic surgeons in the country to actually deal with this. And we use various ways to try to deal with massive bone loss. This includes autograft here. It means once on bone. Usually we remove it from the pelvis, and when it is massive, when it's a lot, usually we don't have enough for us to be able to do that. Allograft is what we are talking about. That is what we are talking about. Where you can get bone from someone else. And the bone substitutes are substances which can replace the worker's bone in certain aspects. Then there are also other procedures where bone can be transported from because actually bone is stronger than even metal, in that it can withstand sacred loading. Now, I don't want to spend too much time on this. All this shows is that bone has certain properties that we are looking for. If we have lost bone, what are the properties that we need for the new bone that we replace it? And basically, we look at the ones at the top, the conductive, the inductive, all this actually means that either bone is like a scaffold, that is the first one, or it can make new bone, or it has the property to cause the tissue longer to make cells that can make a new bone. So when you look at all this, the best bone that we require is your bone, because it has everything. Next one. But but this one is when we now have bone which we get from someone else. It is not the best, but it's good. It provides the scaffold where the body makes new bone on. It's not that the bone that we give is the bone is going to stay there. It encourages the body to make its own bone. What do we require to run a bone bank? The first thing is demand. Demand we have. I'm a member of council of the Kenya Orthopedic Association. And the Kenya Orthopedic Association has all the orthopedic surgeons in the country, and they really require this bone. Right now, we get some of this bone from South Africa or from India, or we use bone substitute. And it's very difficult to get bone from another country. And sometimes, what my colleagues have done is very difficult. Because you go to South Africa, you buy, you keep it in your suitcase, and we hope that when you pass through the airport, nobody asks you what you have. It's because we can't get it, and we require that. Supply is what we are looking for. Yes. That we can have a bone bank to supply it. In order to do that, we require organization and legislation. Legislation has been done. Right now, legislation really basically requires, I don't know, I've not read the one that was launched 2 days ago, that if you can basically have an organ donation, if the minister or the cabinet secretary gives certain regulation to that effect, it's a legal aspect to it. Now, these are some of the requirements. But I'll go to the next one, and then in terms of an organization, Dr. Gejana has talked about, documentation, donor selection. We just want to be sure, because the bone is gotten from someone else. And in this case, you'll ask, how do we get it? Right now, when you do joint replacements, like bone hip replacements, we throw away bone which we remove, which we replace. the important thing is to discuss with the patients who undergo this to be donors, to recruit them as donors. And we need to be sure that they don't have illnesses which can be transmitted, cancer, infection, and any other. Then we need, once we get the bone, that we get it in such a way that it is safe. We handle it safely. And then there are certain tests which are done to ensure that the bone is safe. There are some for certain viruses and some for certain bacteria. And those for the viruses are different ones. There are some which can be done depending on what you do, and then you have to repeat it after about 6 months. It takes a long time before you can leave the bone. Or you can do others which are more expensive, but you can reduce the bone immediately afterwards, maybe in about 3 or so weeks. Then we need documentation to ensure that the bone is safe. Then we require storage and processing. In short, we're talking about you harvest the bone, you keep it safely in a cool place, you put it in a freezer. The freezers that we keep them keep a temperature of minus 80 degrees, and you have to be sure that this temperature is maintained all the time. So there has to be, how many minutes? 5 minutes. Okay. And you have to be sure that during all this time that you are keeping the bone, you can keep the bone for 5 years, that it is in this temperature. So whenever you keep this, there has to be a backup, power, system. And there also has to be an alarm system, which is accurate to enable that to happen. And then this bone, there has to be a way in which we can transport it from where it is harvested to where it is kept, processed, from that to where it is used. So you need a cold chain which works, so that bone can be gotten in a hospital here in Nairobi, for instance, kept in the bone bank, and can be sent to Kitale or anything like that safely. When you have had all these things, some of the areas down there is requirements that you need for safety. Because a lot of what is important in a bone bank is safety. So you train the workers there to ensure that everything is gotten, the bone is harvested in a safe manner, is kept in a safe manner, in the approved temperature, -100 and -80 degrees, and is not contaminated, and is given to the patient in a safe way. All these have to require training in those who are handling them, and a system which delivers these. Now, the Ministry of Health has got a system where they use contractors, G4S, and Poster. They have vehicles which have freezers in them, and they can deliver within 24 hours in any place in Kenya. So, in terms of organization, now this is a concept because we don't have it. We really require, in terms of governance, that there be a committee looking at this. But then, the National Blood Bank Service, for instance, has governance structures, and we have to look at what governance structures will work for us. And at least we need someone who administers the bank and a nurse. I picked a nurse, I talked about a nurse here because they handle quite a lot of these things, and they are used a lot. They are used to document things in a particular way and follow, so that they can train the nurses who handle the bond and also who receive it and all that. But this is something that you can train others to do that. I can talk a lot about this, but I think we'll leave some time so that we can be able to answer questions at the end. Thank you.
Thank you very much, Dr. for that informative discussion. I think something that is really jumping at me as we listen to our speakers is one, legislation and the framework. We keep talking about legal framework to do something. So my question is, why are we so behind in creating these structures that will pave the way for really life-changing and turning point developments in our health sector? I think that's something, food for thought. The other thing is on public-private partnerships. Yes, that was the last point on Dr.'s presentation. We really need to shift our innovations and our problem solving towards this axis. Because private sector accelerates things. They are willing to try things that government is like, no, we are not touching that. It's not in the policies. But if there's more collaboration, if Daktari here was given that legal framework to set up a trial, well, I'm sure he can go very far and then come up with a structure that can be adopted across the board by the government and other entities. Of course, legislation in place. Yeah, those are my two take-home points as the final speaker prepares to come and talk. I think we'll please save your questions for after. I see Professor Tenge is amongst us. I believe he's a pediatric surgeon. I believe he has questions for the end of the session. He was my teacher at Moi University and mentor, and some of these sessions reminded me of the sessions. So I'd like to invite Elizabeth Chelimo, who's a social health worker. No, medical social health worker. We are shifting gears kidogo. Karibu sana.
Good morning. My name is Elizabeth Chelimo. I'm a medical social worker. I'm based at Moi Teaching and Referral Hospital, but we collaborate with the Regional Blood Transfusion Center in Eldoret to help them in the notification department. So I'm speaking on behalf of the notification department today. So in the notification department, we interact with the donors who've already gone through the process, and they're coming back for their results and clarifications of anything they need to speak about concerning their donations and whatever else they need to do after doing their donations. So donor notification is a structured conversation between a donor and a counselor or a notification officer. And the main purpose of the discussion is to discuss on the behavior surrounding the donor and the blood donation services and processes that they go through when they walk to the blood donation centers. And it is important for us to ensure confidentiality, which enables the environment for that conversation to take place. So we also ensure that there's impartiality or being non-judgmental when you're creating that environment with the donor, because if they feel that there's anything that is a bit judgmental or not impartial in the conversation, they have a way of knowing, and most of them will switch off, and the conversation will not be able to happen. So we must have a room that is set up in a way that is friendly, both for the donor and the notification officer. So in the room, we ensure that we greet our donors as they walk in, we enable them settle, we do introductions both ways, and we give them the space to speak up because it is about them and not the notification officer. It's just for guidance. So we still maintain the impartiality in the process so that they don't feel like they're being judged, so that they don't shut down in the process. So we continue to maintain the conditional positive regard, and we be as natural and genuine as possible, because human beings are able to notice, you're not actually connecting with them naturally. So we make sure that we maintain that so that the conversation can happen. And as the notification officer, we need to be informed fully on what we are tackling, because we don't want a situation where you're being challenged with the issue that this person is looking up to you as the competent person in the situation. So what we require well-trained personnel, which is a challenge, like I said, I'm basically from Moi Teaching and Referral Hospital, but we go down to help at the RBTC. Why? Because there is no staff manning those spaces at the center. So there's a challenge, and most of the time, I can say, hakuna personnel amo. So the people constantly look into that. We need our ventilated room. We need to arrange well for a counseling session. And sometimes we need to ensure that it's positioned in a way that the counselor or the notification officer is safe enough, because in few instances you could get adverse reactions from donors. So the safety of the officer should be ensured throughout the process. Phones, adequate airtime, computers, Wi-Fi, ICT pattern. I'm told that Damu-Ke is going to come and sort out most of these technological issues shortly. Why post-donation? Donors seeking results should be given post-donation information and counseling, because it depends on the results that one may get, and if they need, or if they want to get their results, we should be in a position to allow them that. And for those whose lab tests are positive, we endeavor to look for them, follow them up so that they are linked to care. If you find a donor who wants their results, and maybe there's no one present, or they are deferred, or they are asked to come another day, that may create anxiety, depending on the reasons why people come to donate. Most people, apart from the people who are coming to donate for relatives and patients, most donors have other reasons why they come to the center for donations. So for example, someone had tested positive for HIV somewhere else, so they just come in to do a confirmation, and they will be really anxious about the results. So if there's no one to give them the results, the person is going to have anxiety. So it will also help to avoid future transmissions for clients with positive results. If they are taken through a good counseling process, they'll be able to safeguard the other significant others from getting infections. It also helps to enhance donor decision on future donations. For example, if someone gets to know their results and they know that their blood may not be used, they may not be enthusiastic to go back to the centers to donate, because that blood will not be used. And it also enhances and encourages healthy living among our donors. For the donors who test positive for HIV, we prepare them to live with HIV status. We help them to disclose it to themselves and to their families if they consent, and we give information on transmission and prevention. We inform the donor of the positive results, and we refer them to the nearest comprehensive care centers where they can get follow-up services going forward with the management of the patient. In the post-donation interaction, it is important to have the information on what to do in case we have adverse reactions from clients, as I said before. So, like the setting environment should be in a position where the donor notification officer or the counselor can be able to escape quickly in case they see that they are in danger. We give information on regular donations and healthy lifestyles. And we ensure that the donor gets feedback from us on whatever issues they are raising. And at that point, we issue donor cards or certificates which will enhance that. The fact that the donors will have a return date on those donor cards. So it will be a reminder to them that they need to come back to donate again if they are donors who are qualified to donate again. And there is a lot of emotional attachment to the cards and certificates, as small as it is. Most donors feel like they are being recognized, they are being honored for what they've done when we give them that small card or the certificate. So it's an area where it needs to be emphasized, because sometimes when they are out of stock, you find that most donors feel like kuna kitu hawajapata, which they would have wanted to go back home. And it helps also because in that card you put the return date. So it's very important to ensure that those cards are available. So for clients who have other TTI positive results, we link them up to the nearest government facilities, but always people are free to go to any other facility of their choices. And when we have sufficient airtime, we usually follow up and we ask them kindly after the services the other side, can you kindly come back or just text me and let me know that you have been helped, and if you need further services, you will still come back to the institution. But when there is no facilitation, that those gaps exist and it will affect that flow of care to the particular clients that we serve. In the absence of post-donation counseling, donors do not get their rights to know their health status, and by extension, they will not be able to plan their interactions. Donors may not get the opportunity to self-exclude. Like I said before, if you know that your blood may not be used, then you will not find any reason to go and donate again. But interestingly, there are a few clients who will tell you they know their HIV status, but because of pressure from family, and they don't disclose to their family members, so when there is a request, like in the family circle, to go and donate for someone, but they will still be courteous enough to come and say, I know my status, I know my blood will not be used. So the expectations of the family, everybody needs to go and donate. So they will still donate, but they know their status. Others may be coming for confirmations, and yet they still know their status, but they are our clients, so we still handle all of them together. In the absence of this donation counseling, donors will not be able to clarify the misconceptions and myths surrounding blood donation, because there are so many myths from wherever we come from. I'm sure you took examples. Everybody will have their own myths. So when they come in that interaction, they will raise those concerns, and we will have a discussion, and those clarifications will help in reducing those misconceptions around blood and blood donation. In the absence still, it could impact on the number of donors coming back, because when you create that relationship, it's like you belong together, you recognize them, and you make them part of the plan of the next visit. So if we don't have the opportunity or the personnel to sit there and receive these clients, this will impact on the number of donors who are coming back. Like we had in the morning the presentation of Dr. Binji, the friendly environment matters a lot when the client is coming in or coming back. They should be able to find someone when they want someone, when they want to get information from the particular department. Because when they are sent away, like not once, not twice, that will make that person not be in a position to want to come back to that particular facility. The challenges, as I said, inadequate of the trained personnel, inadequate spaces, the information flow between stakeholders is lacking. There's need for research to enhance the donor retention so that we can know the areas where to enhance, where to put what, to enable us to handle the clients in a better way so that we can have a better client retention program. ICT, I'm told, is going to be sorted very shortly. There's need for improved communication strategies, more funding, because it's funds that can make us do all those things we intend to do. And donor incentives is an area where we need to look at. The bread and the soda have been coming up in previous presentations, so maybe it's an area that we need to look at in getting donors to come back, apart from the bread and soda. And we need to be given spaces to go to the communities, to interact with the community structures available. I'm sure from the presentations in the morning, if we go that way, we'll be able to get more structures that are lasting and may not need a lot of resources, because there are so many structures that are out there in the community. Thank you.
Thank you very much, Elizabeth, for your presentation. I think that issue of bread and soda comes up a lot. I don't know, is there a bread and soda committee? Yeah. Well, for me, as with my public health background, I would say let's try and do something healthy. Let's do milk instead of soda, so that the farmers in Eldoret can also get an opportunity to sell their milk. So, but that's going political. So there are some things that keep coming up, and the issue of ICT is one big one, and it's been mentioned in so many sessions. When you speak to somebody in the Ministry of Health, Dr. CTNA is instrumental in leading that team, and maybe Dr. Kenyanya can speak about it later in the session. We are still behind on ICT. The conversation has been, it's coming up. It's going to come up. But if you look at the private sector, it's there, it's been working for so long. Right now you go to the Android store in your phone, there's a lot of health products, health services being sold on it. You wonder under which regulations they operate. Because when you log on, they ask you for your blood group, they ask you for your height, weight. All this is data, the previous diagnosis, any medications you're on. All this is biodata that is important to secure. And this legislation we keep talking about, we needed it yesterday. Yeah? We don't need it in the next few months or with the next government. So that is a challenge really to our policy makers, the people who are driving this agenda. And of course to the people, yeah, when they go to the ballot in a few days' time, just over a month's time. How are we ensuring that our interests are protected? Yes, how are these telehealth providers operating with our data? Yeah, how are we sure of that? What opportunities are we missing? Elizabeth talked about the challenge in donor notification and actually getting them back for follow-on treatment after their blood has been discovered to have viruses that are transmissible and therefore rendering the blood unusable. The use of ICT could very easily help bridge that gap. We want to connect all our health centers in the public space to an ICT system. I think these are solutions that needed to have happened a while back, and I think COVID is helping us accelerate that a little bit, but I think there's still room for improvement. So I think without taking much time, we have about 20 minutes. We need to ask those difficult questions, and I'll ask our panelists to come forward, so that we can engage. Sawa. I'm seeing hata sijasema kitu. I'm seeing hands are already up. Watu wanataka hii conference isha haraka waende nyumbani. Okay, I think I'll start from the back. Yes, so we'll try to spread the questions out, one panelist after the other, so that we get an even feedback.
My name is Damu-Ke. I'm a hospital leader at the National Hospital. And I'm excited of having listened to Dr. Aroko's presentation on bone transplant. When I was training, we went to a bone bank. And when you're talking about deceased organ donation, bones are the ones that are made for giving. You know, like if it's a heart that we are harvesting, it must be used within some 4 hours, liver within 6 hours. Such that if you don't have a recipient who's waiting, you can't harvest the heart. But with bones, you can store the bones up to 7 years. So I think the orthopedic surgeons will be the best beneficiaries for the bone bank. And I think I'm very excited about that.
Thank you. I didn't get a question there. Was there a comment?
First and foremost, I want to thank our 3 presenters. My name is Valerie and I'm doing documentation and reporting for this conference. This is to Dr. Rocco. Now, when it comes to donating and building our bone banking, you know, yesterday we just had a conversation in this room where they said they can harvest your cornea when you are dead. After all, you don't want to see heaven when you're going there, so you can harvest. Now, when you do the presentation, I had hip joint, when somebody is going through a hip joint replacement, then you have an opportunity to donate bone. I was wondering, when this wonderful Violet is taken to go and be with the Lord, can you harvest my bones so that they can be used on a patient, or nikikufa hizo bones ziko as useless as they come? That would be a question I really would want you to address, because then we have an opportunity there. And maybe just a comment, some of these things is just inadequate awareness creation and education. You know, all along we know we can just donate blood. We didn't know blood can be processed into blood components on our platelets. Today, I'm telling you, this conference has become a paramedic. After this, I just get a license. So yes, you can address that part.
I don't know, maybe if there's another, yeah, you can ask and then we can address them.
Good morning. I'm also excited about the presentation. My question goes to Elizabeth. There is a very interesting conversation about the issue of those family members. Somebody knows the HIV status and comes for blood donation. In your scenario, what do you do to such a patient like that? The family members want you to donate. And remember, we have a questionnaire on how to eliminate those people who are not in the criteria.
Thank you.
Still for a few questions.
Yeah, still to Elizabeth, we are talking about post-information cancer.
And I want to tie that with consent when it comes to blood campaign fights in high schools. More often with two blood campaign fight, probably to get 100 units of blood, and probably out of that you would get 3 to 4 of the donated units could be hepatitis B positive, and maybe, okay, or one HIV positive. Now, in this situation, you are actually getting blood from somebody who is under 18 who actually you may not have got the consent. Now, theoretically, when somebody has been diagnosed to have something that needs linkage to that kind of care and management, how do you go about, because disclosing the results will be a problem because there is no consent, and how do you go about so that you ensure that there is client also benefits from your service? Thank you.
Thank you. Let me jump to the other side of the room. Do you have a question for Dr. Nyan?
Probably that might go to that. My name is Edward Mugabe from Moi University in regarding protection of biodata and consent. As much as we want to protect it from the likelihood of ending in unauthorized hands, but whose data will that belong? Who will have the kind of consent to share it out? Will the original donors be taken into consideration? And the other thing, talking about consent, I think even when doing blood donation, consent sort is usually very partial. And there is likelihood that the tissue or the blood taken might be used for some other purposes, as we have been informed. Shouldn't this consent be comprehensive enough for the donor to be aware it might be used for some other purposes other than the blood being given to the relative? Just as the doctor said, they may do a hip replacement and consider banking the bone for some other use. Then the patient may need to know that. So I think it's a comment and a question. That consent should be comprehensive enough for the donor to be aware of what might happen.
Thank you very much, Michael. I think allow us to close questions for hand over to the analysts, then we will have more time to respond.
Thank you very much. I think the first question that I would address is that of legislation. The legislation may not be detailed, but it gives the Cabinet Secretary the authority to actually give regulations for something to happen. It doesn't stop it. The important thing is to be able to engage with the Cabinet Secretary, and there is a way in which government draws up regulations like this. There's a legal department, and then the minister, depending on the need, can be able to do it. So in terms of the bond bank, that is what we found. That actually you need to engage, you need to be able to have a way in which this is developed, and the minister or the Cabinet Secretary accepting it can allow that to happen. But of course, it's better to have more detailed information. Now there's a question about what you may call cadavers donated if one has passed away. Now, bone banking is very wide. The easiest way is to obtain bond from a living donor. And there is a very comprehensive questionnaire. There is informed consent. The questionnaire is very detailed because its purpose is to protect whoever receives the bond. So it has to rule out certain conditions. And those which have not been ruled out, you do blood tests and other tests for safety. Now, that itself in the country also is something which has to be worked on. And this now allows not just bone, but other tissues. Can take tendons, like patella, tendon, bone for the cruciate ligament reconstruction. You can take the Achilles tendon also. So this is very important, but you have to start somewhere and then work. Once you have a bone bank, now you can add other things. But if you come with the whole shopping list, it's very difficult to actually get it to work. So yes, that's where we would like to go in the future. But for now, what we want is what can easily be done. Something that say, look, we have the need, we have the bonds. What we need is infrastructure to be able to harness this and have this to work. Now, there are also different processing, things that can be done. For instance, now, if you have lost that tooth, and you go to a dentist, they tell you it's an implant. Now, before they put this implant, they also need bone. So ask them, where do you get this bone from? Oh, this bone we buy from another place. Of course, not in the country. It's brought from elsewhere. So there is a lot of need for bone. If you have had an implant, you have gotten somebody else's bone. And actually, I have not had an occasion where anybody does not really say, I can't have somebody's bone or something like that. I've not used a lot of, in this country, I have not used a lot of bone banking because it's limited. The ones I've used are bought from South Africa. But in another country, I used to use a lot of bone grafts, and there was no issue. Patients did not have a problem. And this bone here, I can have bone from someone else. And because, her name said, bone is very forgiving. If you do kidneys, you need to give a lot of medication to suppress rejection. With bone you don't. Just give it. It works. It's only very occasionally that it gives any problems.
Thank you very much for those challenging questions. Let me start with the one for students. Like the discussion happened in the plenary in the morning, it's a very sticky area, and the issues of consent is critical, but most of us in this room know that those strikes happen without parental consent. for the children. But occasionally, those positive results will come. So what we try to do is to work with the students and eventually work with the parents so that we can come into consensus and get into helping that particular student. But I can tell you, it's not very easy. Tunatumia mpaka hiyo akili ya kuzaliwa na ile ingine ya kawaida, apart from the training that we have, because we don't want to damage families in the process of trying to help them. So it's a very difficult balancing act, but someone has to work with that difficult act. And for the family members who put pressure on neighbors who know their status, the few that I met actually know how to go about it themselves. So they will go through the process, they will do the questionnaire, and they try to keep themselves busy through the processes in the center. One told me she had to actually donate, but the other one that I met was able to go. I think that person had done it severally, so you got a job delay, utachukua questionnaire, then you go, you get busy, you enter into one of the other offices, you come out, you go out, they know how to play their own game. But again, we have a duty to ensure disclosure happens. And again, it's a difficult balancing act, because if I know that this person is married to this other person doesn't know the status, the law allows that, but again, you cannot just say the law allows, so I'm going to do this. It's a very difficult balancing act that happens, but I can tell you it's not a very easy, straightforward process. Thank you.
There was one question regarding biodata and biodata security and consent. Who owns that data? Appreciating that you have rightly pointed out in everything that we have more or less done as human beings in terms of collecting any form of data, whether it's personal data, whether it's biological data, or any other form, we haven't really communicated the terms and conditions of that, where it ends up. Right? So, true, that particular concept is needed, and it needs to be comprehensive. But I need all of us in this room to also rightly question themselves. Whenever you see those terms and conditions bits, do you ever read the entire document? Because you have to be aware that I think generally what would be stated, and of course this is feedback that will go back to the team that's working on the telemedicine project, that all this data will need, whoever it is, yourself, walking to a clinic, as he said, the apps ask you for information that you freely give out, and you don't know where it ends up. So there's that bit of, I have read the terms and conditions, and you really haven't read it, you just check it, so that you can get into the next page. So with regard to who ends up owning it, the idea is that with regard to biosecurity, that particular data is anonymized as soon as it gets into the system. So that by the time it's being fed back, it's being fed back as aggregate numbers and not necessarily. That's what we have in the KHDS. So it comes out as aggregate numbers and not as the patient. Unfortunately, in some of the systems that we know are in existence in our health facilities, we can be able to drill down to the person and where they stay. There is no anonymization that happens there. And that's what now all these laws and regulations that, again, we've taken forever to get to are going to cure, so that we can be able to ensure that this happens in a way that makes sense. I'll give a case in point of a certain private facility in this country where part of this data for patients, pediatric patients specifically, who are on HIV medication. Unfortunately, this was supposed to be internal data, so somebody printed out one sheet so that they could work on it, and then since they are doing some proper cost-cutting mechanisms, the reverse side wasn't used. So they used the other side, the blank side, to print out another notice that was supposed to be put on the wall of that particular area, office area. within the hospital. Then time went by, the notice was never removed in time, and then it got used and it fell down. So it fell down, it flipped, and showed the data that was there. So you see, those are things that happen, that even happen in places that have established systems. So those are things that are going to work towards it. And also, as the stakeholders, as the person who's actually giving the data, you have to question, where is my data going to? Because if you're also not clear, if you're not comfortable, then you shouldn't actually give it out.
I would also comment on the data. I think there are two types. For the donor, we need to keep it for some time. I think in this country it is 7 years that data is. Yes, actually that is in a longer time. Because what happens if you miss something and someone develops a problem later on? They might say it's because of the bond that I had, and be able to go back and trace that. In some countries, it's kept for 30 years, not anonymized, but you can be able to trace back. But I think our laws, I wanted the 21 one, but I was told it's 7 years.
21. You can keep your files for 21 years.
That's what the law requires, actually. It's just that people don't do it and we don't go back to ask for it.
So, maybe engaging discussion. Yeah. Yes. I'll go here first, and then jump to you.
Okay, I'm I know we have talked a lot about collaboration, organization, and issues. But as I was seeing just we are still having a long way to go because we don't have strategies how to look at the communities. We are going around having some many conferences and we are looking to communities and we have never even utilized the power to get people who are engaged most of the time in the communities. It is high time we change our strategy. Otherwise, we remain like this forever, using a lot of resources, but we need to lead the community so that we can bring them about the importance of token and distribution and blood donation and demystify any myth right from the community.
Yes, we really need to remember that public health is about that individual.
I'm done, thank you. You talked about individuals who are positive, they come to the hospital and they know that they are positive. I think in this sense, these are people who require assistance from us. Because now they are open, they tell you, I'm impressed by my family. So instead of wasting that one, processing blood is expensive. The blood bank itself is expensive, processing, screening, all that processes utilizes a lot of money. So I think these people require some assistance. Probably we can give them options where we can disqualify them without disclosing their status. Say for example, they sit down, we tell them, okay, you can do, instead of this, let us base our qualification on something like a D. Yes? So that they can just go out, you tell them, okay, we have been disqualified because of a D. Yeah? Something simple like that. Rather than going through the whole process, you claim you have collected, say, 50 pipes, but 5 of them are positive. And in that sense, you are also, your TPI percentage is also going up. Yes, that's wrong. Because this person, each time they donate, you will repeatedly be capturing such a person, and in the end, your TPI percentage will also be had. So I think we can assist them by giving them options. Thank you.
So in short, just to reframe that, in short, we are asking our health workers in that position to concoct something, to collude, with the people who are, who want to be dishonest to solve a problem. I don't think that really works well.
Let me just say this, that this is at the post-donation section. So it depends on how they fill their questionnaire initially when they were coming in. So this is after donation. So there's nothing like misleading anyone.
I think we've had too many men speaking. Since I'm on this side, I will pass it on to the lady and then jump over there.
Good afternoon. My name is Damu-Ke. I work with the Blood Transfusion Center in Eldoret. Now, it's just a clarification on what we're discussing about these patients who come in and they're HIV positive, then they still want to donate. Most of the time, as she put it, they come because of being pushed by the family members or friends to come and donate. They don't want to disclose their status, and they have a right to that. But when they come in, one of the questions of the questionnaire actually states that have you been tested or your partner? So at that point, if they do their status, they usually tell you and why they are there. Because a counseling group, you are just the donor, the two of you, and they open up. By the time they get to, we rarely have donors who donate and they know their status. Maybe one or two. But again, if they donate, like at times we're in the open air and that privacy is really not there, and they happen to donate. At times, somebody can sneak in and tell you that I've donated, but that unit is not good for consumption. And we mark the unit. We mark the unit, and the unit will not be used. But once in a while, you get one who doesn't want to open up, and they just donate, and that's how they land in the post-donation room.
Very rich discussion. Let's jump over to this side.
Yeah, I'm in a my question is I think it's more government and a question will come out of it. The Data Protection Act came out in 2018. We had to start the implementation. I think it's the first case who actually have data protection officer. But I strongly believe the health sector has been marked as one of the sectors where it handles and processes and controls sensitive data. I am hoping in the spirit of this conversation that we will all go to one of our hospitals to make sure we are obliged to the Data Protection Act. Because the Act is actually answers most of the questions everybody has asked, from consent to how you store your data, how you retain your data, how you do everything. And if you follow it, it will come to process. Yeah? And the issue of telemedicine, in fact, has become the most agile for telemedicine in the public sector, although I don't do it very public. But what I can say is, I am only speaking on behalf of public hospitals, the data protection, we've piloted like from zero. The data protection is key to us, and it was a gap, but it is being incorporated in the standards, and the standards will be fully fledged, and it will actually be not only a pilot for telemedicine, but a pilot on how to treat data correctly, according to the level. Thank you. And so now I actually have a question. Yesterday we learned about plans to quite a limited discussion. That he said you don't need to do histo HLA tissue typing for the body. Nowadays, it's the same for both.
Yes, the same for born. You don't need to do that. Yeah, same for born. So really, born is something that can be done. Not too expensive to do it. If we do it, say, countrywide, if you look at the infrastructure that you require, and apart from the tests that you do, which basically are the viruses, HIV, HB, hepatitis B, hepatitis C, HTLV, syphilis. Apart from this, you also get a part of the bone and take that for culture sensitivity. And that takes about 2 weeks. Now, depending on what you do, if you just do the viruses, because some viruses take time to be detected, then you require to repeat this after some time, usually about 6 months, before you can give this blood, this bone. However, if you do nucleic acid testing, as PCR, it's more expensive, then you do not have to wait. And so, for our country, it might be better to go for what's more expensive, the nucleic acid testing, so that the bone can be immediately available. Of course, it will take about 3 weeks because we are waiting for a culture sensitivity, which takes about up to 2 weeks. And also look at the documentation, that all the documentation is proper. And the various standard operating procedures which are there. For instance, you take 2 specimens, 2 pieces of bone. One you put it in aerobic, another one anaerobic medium. If one is positive, or 2, then the bone is lost. So they have to be negative. And you have to also, your questionnaire has to also be negative for any of these conditions. The other problem of doing what is cheaper, in this case, cheaper is more expensive. Because you do these tests. If you call the patient after 6 months, you may not get them. Maybe they came to Nairobi from another place in the country, or they don't actually want to come at this time. Who is paying for their transportation? Who is giving the soda and the bread? So probably it's better we go for nucleic acid testing. You just do it, and then the bone is available. You don't have to follow with that.
Thank you very much, Doctor. More questions for the panelists?
Thank you very much for a very insightful conversation. It's a pleasure to be with you. My name is Lilian. I work with Romeo. My question would be to, let's work with the blood sample. When a blood sample is collected, that is for evaluation, this finds that, let's say we follow the right procedure for collection. Thereafter, there's a storage that's supposed to be done in the right way. When the transmission is taking place, do you have any data that may show us that in case there was any contamination during the collection, maybe the donor was okay, the procedure may be going correctly, we may have introduced healthy pneumothorax from the skin to those particular lines. Do you have any data that show where we got some infection of recipients, that is the patients, after transfusion?
I don't know who's better placed just to answer that question, I think.
Thank you. Hello everyone. My name is Grace. I'm from American University Hospital as breast section. I think I can try and answer the question that you have asked regarding the aseptic techniques of blood collection. I don't know whether maybe in the government institutions they are able to do quality controls of their products. And the quality control of the products, you monitor the processes from the collection from the donor until this unit is transfused. You cannot monitor a bunch of a whole like 100 units, but you sample. So you sample like 3-4 products in a monthly basis, and then you do the blood cultures, and also you look at the quality of the hematocrit, the quality of the red cells, and if it is like a product like bioprecipitate, you are able to check the quality of the fibrinogen levels. So I don't know whether the government institution is doing that, but it is a very, very important aspect because you are able to monitor the processes. For the previous that expire like within 5 days, you can sample at the third day, and from that you can be able to correct normal flora from the skin if correction was not acceptably done. Yeah, so basically that is what happened. And also, let me add on the issue of donor, a donor who donates, and maybe they are seropositive, and they know that as much as we need this blood, we need to look at the health of a donor. Remember, if a donor donates and they are already sick and they are donating, so their HB is compromised. So I don't know whether they do HB levels for these donors. Because at the end of the day, we can be able to tell a healthy donor and a donor who is not supposed to donate. And then educate them the importance. As much as we are saving life, we also need these donors another day and another day. Thank you.
Okay, may I ask something on that? In Kenya National Drug Service, as a government facility, we have nurses who are running, and they are well configured. You take a week of program a week before you receive a big plan. And we have standards for that. And I want to say that also we have Nutritional units at the National Drug Service, whereby we can follow up with the donor. We can start Nutritional right from generation or after donation, even up to the bedside. So I can say from fail to fail. If any problem arises in between, we can come up with measures, preventive measures from stopping it again from recurring. And we encourage both government, mission, and also private hospitals to give us data, be practicing more vigilance so that they can be sending data to us, analyze those data, and we can follow it up to the donor. Thank you.
Thank you. I think we are heading towards the end of the session. It's time now to consolidate all this discussion, all the learning we've had, and come up with our key take-home messages, as well as recommendations, because remember, part of the objectives of this conference is to give recommendations according to the presentations we've had, on how we can now take these conversations forward. I think one of the key elements, as I mentioned earlier, is the regulatory framework that needs urgent attention, needs to be set up, both on the ICT side that will help us manage all these interventions that we're talking about, and also in the actual practice of, in this case, we're talking about bond banking, creating bond banks, managing the donors, and how to streamline all that so that Daktari is able to serve that patient who is in need. And I think I'll take it back to the panelists once again so that they can give a summary, and then our rapporteur will also chime in, and we can close the session. Let's start with Elizabeth.
Thank you very much. I'm grateful to have been part of this discussion, and I thank the organizers for inviting us to participate. So, in the area of notification, I would suggest that the concerned bodies or departments consider employing staff so that there are people on the ground to handle that section of the process of blood donation, because it is important, it's critical. And I'm told Damu-Ke is coming, so I'm sure that will enable the person at the notification section to give the messages. Like, I'm sure it will be giving SMSs directly after the donation, so that will keep the reminders for the donors to come back. So that I was told it will be up and running shortly. So I'm kindly asking the people responsible to ensure that they do that, so that it can help the people on the ground to manage the donors well. And as much as we have the regulations, we have the guidelines, sometimes we have the in-between decisions to make when we are serving the clients. So I don't know if there's something that can be done, like someone suggested in the morning that we do some consent form attaching to the reports from schools that go to parents, so that we can actually have parental consent